Welcome, and thank you for joining us today. Before we get going, a brief message for our French speakers. Merci également à nos francophones d'être venus aujourd'hui. Vous pouvez recevoir une traduction simultanée. Il faut cliquer sur le globe, puis cliquer sur la langue qu'on veut entendre. Merci beaucoup. My name is Rolf Rosenkrantz. I'm the Associate Director of Communications at the Global Health Advocacy Incubator. Today, we're going to discuss how journalists can effectively use data to report on the human impact of COVID-19. Last week, the Partnership for Evidence-Based Response to COVID-19, or PERC, released findings from its third survey, which polled more than 25,000 adults in 19 African Union member states on topics related to COVID-19 and the public health and social measures. The survey aimed to uncover the type and extent of secondary burdens resulting from COVID-19, including access to healthcare, food, and employment. The 19 briefs compare findings from the most recent survey, which was conducted in February, with results from a similar survey conducted by PERC in August 2020. The briefs contain insights about anticipated vaccine uptake and how support for and adherence to public health and social measures have changed over the past year. These briefs are intended for use not only by high-level decision makers, but by journalists like you that are reporting on the ongoing COVID-19 pandemic. Journalists have a powerful role in disseminating information about COVID-19 to the public, so I am particularly delighted that you are joining us today. PERC will publish a report summarizing findings across all 19 countries later this month in April. And to share more on the insights from the report, I'm privileged to announce our distinguished panel of experts. Virginia Nkwanzi is a Public Affairs Director for Sub-Saharan Africa at Ipsos, one of PERC's partners. Dr. Wilmot James is a Senior Research Scholar at Columbia University and a former Member of Parliament in South Africa. And Dr. Da Costa Awagie, Director of Health Promotion at the Ghana Health Service. For those joining us on Zoom, we will use the Q&A function at the bottom of your screen for questions today. If you have a question during the remarks, please enter it into the Q&A box. For those on the phone, you can send your question via email to press@vitalstrategies.org. That is PRES@vitalstrategies.org. We will make every effort to answer as many questions as we can before today's briefing ends. And with that, I will hand it over to our first panelist, Virginia Nkwanzi. Thank you very much. Please take it away.
Good morning, everybody. My name is Virginia Nkwanzi. I am the Director for Public Affairs at Ipsos Sub-Saharan Africa. I am pleased this afternoon at my side of the world to present to you the results of the PERC study that we did in February 2021. So before I get into the data, I would like to first take you through the methodology briefly. Next slide, please. So this is an overview of the methodology that we used to implement this study in the 19 countries. The survey was conducted in 19 African Union member states across Africa, with an average sample of 1,300 respondents per country, and the overall sample was 25,640,000. The survey was conducted using telephone interviews where we reached a population of 18 years and above across the 19 countries and across the different socio-demographic characteristics. This survey is the third of its kind, which gives us the advantage to trend. So the first two were done in 2020, one in April 2020 and another in August 2020. So it gives us an advantage of trending the data to see how the changes are happening across the countries. In terms of the results and how they are presented, we have specific country briefs, but we also have regional data for each of the countries. And in terms of the regions, we have 4 specific ones. In East Africa, we have Kenya, Uganda, Sudan, and Ethiopia. And in West Africa, we covered Ghana, Nigeria, Guinea-Conakry, Liberia, Senegal, and Cote d'Ivoire. And for the Southern Africa part, we covered South Africa, and then Mozambique, Zambia, and Zimbabwe. And Central North, we have Egypt. We have Egypt, Cameroon, Morocco, Tunisia, and DRC. Next slide, please. So part of the study methodology involves different aspects of data. So in survey 3, which took place in February 2021, at the end of the second wave of COVID-19, the cases in the African continent had had increased significantly. And the reported cases cumulatively almost doubled what they were during the survey in August 2020. This is an important statistic to keep into context as we analyze the data. So the table that is currently being shown on the slides shows 4 key indicators and the change from August. So while the risk perception has stayed the same, this has varied widely by country, depending on the epidemiological situation. So support for public health and social measures that require you to stay at home has decreased, while income loss has increased. And we also see that satisfaction in the government response has increased, but only by a small percentage. Next slide, please. Thank you. So one of the other issues we tried to find out in this study is the risk perception. And generally what we see is that risk perception is lowest among the countries in West Africa. And we see that there is higher risk perception in relation to expectation of more people being infected in the country, but significantly lower risk at a personal level. What that means is that while people or the population in different countries is seeing that the cases may be increasing, which increases the risk at a country level, it is felt that the personal risk of getting the virus is still low. I'll give an example of Mozambique, where we see the highest belief that more people will be infected. But then when it comes to personal risk perception, it is only at 47%. Now, a point to note here is that in Mozambique, they had just undergone their first major wave in January and February, around the time that we implemented the survey, potentially attributing this perception that COVID will affect many people in their country, and moreover, including reports of the variants. There are various cross-country, there are variations across countries in relation to those who feel that they will be personally affected, from as low as 18% in Guinea to as high as 84% in Mozambique. The next slide, please. Thank you. So then we go ahead now to look at the public health and social measures support and adherence. And one of the things that we see that generally support and the PHSM support and self-reported adherence for individual PHSMs were found to be generally high across all the countries, with some differences though by region and by country. While results show support and adherence is high, there is generally decline, especially with social measures and movement restrictions. And we believe this could be attributed to many of the countries easing the lockdown and also to the economic burden that the pandemic itself brings to the population. Next slide. Now, talking of the economic burden, one of the things that we see in the findings is that income loss and food access are getting severe. And this is seen from 77% of households who have lost all or some of their income since the beginning of the pandemic, with 15% saying they have lost all and 62% some of it. We also see that 81% of the households have experienced at least a barrier or one barrier to accessing food in the past 1 week before we conducted the interview. So what we see in the table here is that the key barriers that may lead to limited access to food, one of them is high prices. And then we also see reduced meals and shortage in markets. But again, we also see that restrictions in movement and food markets being closed might be a factor that leads to reduction or severe reduction in food access. Next slide. Again, now looking at trust, one of the things that we find out is that the population generally trusts the government across all the countries and regions, which is a good thing. And this is, we see in the level of satisfaction that is stated by 70% who say they are satisfied with the government response in responding to COVID-19. But also, apart from government, there are also other institutions that have been at the forefront of the pandemic, of fighting the pandemic. And we see prominently the World Health Organization being trusted by 79% of the population across the 19 member states, hospitals within the member states at 79%, and the ministries of health at 76%. Next slide. So of course, it would be unfair to end this discussion without talking about the vaccines. And one of the things we looked at is vaccine acceptance and what would be those hindrances to acceptance. Overall, we see a relatively high acceptance of the COVID-19 vaccines across the African Union member states. And we see that at least across all the countries, at least 2/3 of the respondents would accept taking a vaccine if they came across it or if it was made available. When we look at findings in specific countries, we see that there are variations. In some countries, the acceptance is high, with 73, for instance, in Nigeria, and Ghana at 58%, Uganda at 85%, and 59% in Kenya, Tunisia and Cameroon as low as 35%, while Morocco is at 91%, and Mozambique 75%, while Zambia is at 53%. Now, one of the things that we also sought to find out is for the people that would not accept taking the vaccine, what are those factors that hinder acceptance of the vaccine? And some interesting findings here. First one being low risk perception. So for example, in countries like Uganda, we found that 21% would not accept taking the virus because they feel they are not at risk, taking the vaccine because they feel they are not at risk of getting the virus. And a number of findings across the different countries of those who believe that they are not exposed or they are not at risk of getting the virus. Another one is misinformation. And this is very strong in relation to vaccine acceptance. So one of the findings, for instance, that we find out in Zambia is that 35% say that the vaccine is lethal. And another 35% saying that once you are vaccinated, you actually get COVID-19. So these are some of the things that are likely to deter people from being vaccinated. But also we see that there is misinformation or lack of information about the vaccines. And we see strongly 51% in Ghana saying that they would not take the vaccine because they don't have enough information about it. So these are some of the things that need to be addressed through communication and through different policy strategies undertaken by the African Union countries. Thank you very much for listening to me.
Thank you very much, Virginia, for giving us just a glimpse of the plentiful data that PERC has collected. For more data on PERC, you can go to preventepidemics.org/COVID-19/PERC. Thank you very much. Let's move on to our next speaker, Dr. Wilmot James, Senior Research Scholar at Columbia University and formerly a Member of Parliament in South Africa. Dr. James, please take it away.
So good morning, good afternoon. I'd like to thank Resolve to Save Lives for inviting me to speak here today. So if I can get the first slide, please. By way of background, to say that a group of us based at Columbia University and at the Brenthos Foundation in Johannesburg, we were commissioned to undertake a review of pandemic response in 5 African countries: Egypt, Ethiopia, Kenya, Nigeria, and South Africa. And the review covered public health. It covered the economic impact of the social measures introduced to deal with the pandemic, and it also covered issues around governance and trust. And the PERC data provided a series of clusters of information that was invaluable to our study. And in fact, we could not have done the study without the extraordinary information generated through a variety of data points through the PERC partnership. Our report was released by the Director General of the WHO, Dr. Tedros, in January. And coming out of that effort, Smith Futures, which is a philanthropy that was started by Eric Schmidt and Wendy Schmidt. Eric Schmidt, as you know, was the former chairman of Google. We launched a working group on vaccine safety as it applies to Africa. And what we are going to do is monitor safety levels prior to license and safety levels after license, heading into the future. And therefore, we have taken a very, very special interest in information around vaccine take-up and willingness. As you can see on the screen, if you look at the data points to the right, collected through the Ipsos survey, the level of vaccine willingness by country. And the information provided here is a little alarming, given what's required to achieve herd immunity on the African continent and elsewhere. And so you can see that the lowest level of population who are willing to accept the vaccine when it appears is Tunisia at 35%. Next, Kenya, then my own country, South Africa, followed then by Nigeria, and then Egypt sitting at the highest. So each one of these numbers tell an individual story. That percentage is shaped by a history of vaccinations in the country, and vaccinations in countries prior to COVID essentially involve children, not adults. So this is a very different kind of figure to deal with. But what this tells you here, on average, is that we actually have a mountain to climb in closing the gap between what people are willing to accept as for vaccination and what's required for herd immunity. That figure varies, but we are way behind in terms of achieving a good percentage for herd immunity. If I can get the next slide, please. So the information revealed here, generated again, obviously through PERC, is a specification of the top reasons, the 3 top reasons why individuals don't think they ought to be vaccinated or won't accept it. And you can see by category what the reasons actually are. What's important to note here is the second and third cluster, because that is a body of information that we need to address when it comes to risk communication. So you can see the first category, and it applies in this case to South Africa, Nigeria, and Canada, and Kenya, is essentially virus denial, which is a hard thing to break when people have reasons to believe that the virus actually doesn't exist. And that's influenced by a series of factors that are very difficult to crack. The second one, this has already been raised as an average figure, has to do with risk perception. And there's a normal disjuncture, as you know, between individual risk perception and national and group risk perception. This is also a hard number to crack in terms of risk communication and reducing that, but it's something that can be seriously addressed if you have the right strategy. It's that third category that is really important here when it comes to the role of the media, understanding that, and the role of policy, is that a high percentage of people say they simply don't know enough. It's a simple lack of basic information. And that is where you can make the biggest difference in terms of having successful risk communication strategies. Let me also say the question of vaccine safety, a perception that shortcuts are being taken, whether that's true or not when it comes to vaccine testing, is an important consideration. In the case of Tunisia, one of the top reasons is they simply don't trust the vaccine, or they don't trust health authorities. The third slide, please. Thank you very much. This is a bit of a cluttered slide, but to say that these are important elaborations of who the 5 most trusted institutions and individuals are in terms of favorability. And if we simply look at the figures as a whole, you can see that the medical public health cluster is fundamentally important to whom these people trust, whether it's an individual physician, whether it's community health workers, hospitals, health centers, sometimes ministries of health, not always. In the case of national public health institutes, that applies largely to Ethiopia. The figure's a bit misplaced there. And medical professional associations. So most of the countries specified here, and I've simply looked at the countries with the highest rates of infection to review that. You can see that the medical health establishment are trusted by people, sometimes to include government ministries as well. In the case of global organizations, the WHO and UNICEF play a big role in Egypt, Nigeria, and Kenya in terms of shaping perceptions around whom to trust. It's very important to note that only in the case of Tunisia is the army and military and the police ranked in the top 5. For the rest of the countries, they're not. And there are individual reasons for that. In the case of South Africa, the role of the police and military when it comes to upholding apartheid, this is a long time ago, but that legacy still endures. There's a fundamental mistrust of the army and the military. But you can see that in other countries as well. In the case of South Africa, the president has individual credibility. And in the case of the media, the credibility only applies in the country of Ethiopia. The takeaway from the slide are the following, if I can get the next slide. In terms of what to do, it's important to emphasize that when it comes to vaccines, we've got a supply problem in Africa. We have a less of a problem in distribution, but that is a problem as well. What's fundamentally important to dealing with the pandemic is to accelerate vaccine uptake. And therefore, it is of the greatest importance that the policy implications of what we just looked at have to be addressed. And I list those on the screen. Countries must up their game from a policy point of view. There must be as much smarter use of those individuals and institutions that are trusted by communities and citizens, for them to be the communicators of risk. That communication must happen from the top down and from the bottom up. It's fundamentally important that the media play a role in that effort. As you can see, to close the gap for people who simply don't have enough information. There's a thirst for information, and that thirst has to be satisfied, and media institutions can play an important role there. We don't like micro-targeting when it comes to advertising, but micro-targeting of audiences are very important. And we know that cell phone penetration in Africa is extremely high. And you can do that through text messaging, which doesn't take up a lot of space. And so micro-targeting of audiences using the data that's generated through PERC can make a very big difference in terms of closing the gap when it comes to information. The media needs to report local news and build trust with local communities and tell stories about the efforts made in communities and let's say ordinary citizens, not that we are not ordinary, but ordinary citizens to in fact speak about what it is local leaders and local communities are doing in terms of vaccine take-up. We know that community health workers play a key role. We have to get the messaging right. There has to be transparency, there has to be disclosure, and the truth has to be told. Evidence-based communication around COVID-19 is fundamentally important. People do not want to be lied to. Nobody wants to be lied to. And so there has to be that level of transparency. Journalists have to play an important role as watchdogs in the era of social media where there's no editorial curation. And they play the role as watchdogs by making sure that their reporting is fact-based. We've got PERC data now as a body of fact to in fact use as watchdog material. There's an effort obviously to upscale government regulations when it comes to especially social media platforms. And we need to look at the role of big pharma and the pharmaceutical industry in supporting vaccine safety information, because the more you provide that kind of information, the more confident people become in taking a particular vaccine. The next slide, you've seen the material for Africa as a whole presented by Virginia. But here you can see what those figures look like for the individual countries here, including those countries that sit in the top of the hierarchy when it comes to gross national product. So you have the wealthiest African countries here. And these figures are not only alarming, they are staggering in terms of what's going on in on the continent. Is that the impact of COVID-19 on the continent has been monumental and severe when it comes to the economy and the level of income loss that individuals are experiencing. Look at that figure around missing meals. People are missing food on a vast scale. And so this is an unfolding tragedy that has to be addressed. The last two categories around the difficulty of getting medicines, that you can see there are two figures there. The first figure was taken with the first Ipsos survey, August 2020, compared to the second. And you can see that the second, the last category, which is far more difficult to address, has remained fairly constant, except in the case of Ethiopia, where it's in fact improved, but in other cases it's gotten worse. The question of access to medicines is easy to address, but you can see there's really no fundamental change in what is going on in terms of access to medicines. And if I can get the last slide, please, is that the policy implications here are the following, that there has to be a targeted approach to dealing with food distress right now when it comes to interventions. On the continent, it's not just a food shortage, people are in distress when it comes to access to food. To the extent that countries have existing social protection programs, and not all African countries do. South Africa has some, Kenya has a limited degree of social protection. In the case of Nigeria, it may be on a local basis in some states and so on. Those have to be extended and those have to be upscaled. Countries that do not have social protection programs, there's a need to address that policy-wise. There has to be a constant effort made to lower barriers to market access. We need innovation in the logistics when it comes to delivery of medicines. And there are all manner of models, even in the resource-stressed countries, where telephones can be used and text messaging can be used and digital instruments can be used to accelerate home delivery of medicines to people who need it. We have to lower barriers to access to healthcare facilities. That's a long-term problem, but to the extent that those things can be addressed. And finally, there has to be a rapid scaling up of the provision of primary healthcare mobile clinics and community health worker programs. And with that, if I can just thank you again for your attention. And I'm happy to take questions.
Thank you very much, Dr. James, for those insightful remarks and for underscoring too the importance of risk communication and the role of media in addressing the outcomes or the challenges related to the pandemic. And now it's my great pleasure to introduce to you Dr. Da Costa Awargiye, the Director of Health Promotion at the Ghana Health Service. And apologies if I mispronounced your name. We're very excited to have you. Thank you very much. Please take it away.
Thank you so much. Good afternoon, evening, morning to everyone. I will be presenting on using data to communicate with communities using the Ghana specific example. Next slide, please. So as you heard the previous presenters presenting on the findings of the February PERC survey, in Ghana, we in January recorded a second wave, and the infections actually were a little bit drastic. So government had to take or tighten the public health and social measures. As of February and currently, the active cases keeps declining. But support and adherence to the public health and safety measures was high compared to the other member states based on the findings of PERC, especially in West Africa region. And however, the support and adherence was low for avoiding places of worship and public gatherings than for other measures. And as I go along, you'll see some of this evidence. A self-reported adherence to the social measures decreased by 10 percentage points since August 2020. And these were largely driven by about 13 percentage point drop in the adherence to avoiding places of worship. Although the COVID incidence in Ghana is high, the overall risk perception was low. As we heard from the first presenter, within the West African region, the risk perception is very low, but that of Ghana was very low. In terms of satisfaction with government's response to the COVID-19 pandemic, in fact, the report, the findings shows that it is very, very high at about 80%, but notwithstanding, it is 6.6 points lower than as recorded in August. And I'll show this to you as we go along. Next, please. So if you look at the trends in terms of the highlights, the risk perception in terms of the Ghana specific situation, comparing the August and February surveys. Here we've titled it as second wave, wave 2 and wave 3. So if you look at the risk perception, it was 24% in August, but 22% in February, a 2% drop. Support for staying at home, 72%, and in August, and 65% in February, so about 7% drop. Government satisfaction was 86% in August, but now 80%, about 6% drop. But the most significant is the income lost. In August, it was around 67%, but in February, it was 76%, which is about 9% increase. So as journalists, this is where we have to also highlight for government to inform policy in terms of its economic and social measures and the other measures that governments across the African continents are taking. Next slide, please. So in terms of whether people supported or followed the measures, I mean, if you look at the trend, in August, in Ghana, the support for the individual adherence or individual measures was around 95%, but in February, it dropped to 90%. And if you look at were people following the safety measures, in August, it was around 76% in terms of the individual measures, and in February, it dropped to 74%. For social measures, in August, it was around 64%, and it drops to 55% in terms of people's support. Then in terms of people following the measures, that one, the social measures, that one also dropped from 44% in August 2020 to 34% in February 2021. In terms of the economic measures, whether people were supporting it, it was 67% in August and dropped to 58%. Then in for people following that, it was 38% in August and 32%. So this clearly shows that governments and obviously communities, countries do have to do a lot in terms of people's compliance and also support for economic, social measures. Next slide, please. So, like I said, this is where I think Ghana has been celebrated across the world. I mean, this is not the only report putting Ghana high in terms of management of the COVID-19. If you look at it, the regional average was 78, but the government of Ghana, the president and the task force performance and satisfaction within the population was 80%. So in this case, it is really, really high. But there is one significant thing as well. A larger share of our respondents from the survey also trusted the WHO, and it could potentially be related to the consideration support it provided to the Ghana health system. So this is very significant, and I think this is how journalists can also still use the data in reporting to the outside world and the whole world what Ghana has been able to achieve, so that other countries can also follow. Next slide, please. So in terms of whether people understood the risk, respondents that we actually contacted said that, there were respondents reported lower levels of stigma towards healthcare workers and those with those who have actually recovered. And over 60% of the respondents believe that herbal remedies could actually help. And this is really evident because when you come to Ghana, you see that a lot of people are actually taking herbal preparations and others. So, this is why we certainly have to continuously enhance risk communication and community participation. In terms of stigma, I'll talk about to link that to mental health in the next slide. So please give me the next slide. So in terms of people's anxiety, how people feel about resuming work activities. Obviously, we know that when people have lost their income, as the first and second presenters actually alluded to or presented, it definitely affects their mental health. And it is very, very important that we sell this to African governments and stakeholders so that we use this in addressing mental health and stigma and its related. So we have the data breakdown as higher income respondents were more likely to have resumed normal activities, suggesting motivation beyond financial necessity. And respondents with lower risk perceptions were more likely to have resumed normal activities, about 56% than the respondents with personal risk, about 37%. So the Ghana data actually now supports what actually the two presenters gave. The fact that there is more that is needed to be done to address mental health issues and the lost income. Next slide, please. So whether people, what do people think about the vaccines? Yes, of course, hesitancy is a major problem in Africa and the world. And Ghana, if you look at the data, seems to have about 51% hesitancy. So it means that about between 51 and 52. But if you look here, so about 58% of the Ghanaian population actually plan to take the vaccines, but the regional average is around 68. So it means that we still have a lot of work to do in Ghana. And it is the reason why we are relying on the PERC data. Bear in mind that Ghana was the first to receive the COVAX facility, but being 10% lower within, obviously lower than the regional average is a little bit worrying. But the PERC data will certainly help us to take measures in addressing some of these challenges to make sure that uptake is very high. Next, please. So there is one aspect that in terms of the public health and social measures that we took in Ghana generated a lot of politicization, and it is the testing of passengers at our airport. And let me say that it is also one of the key measures that we took in Ghana to protect the citizens and prevent importations of the virus into our country. So in December 7th, Ghana had its general elections, and we saw that there were a lot of politicization around the testing. Though let me state that governments provided free testing and treatment to the public through the public health systems. But the price of the testing at the airport generated a lot of controversy and a lot of sentiments from overseas travelers. But on social media, the agitations were very, very, very strong. And I think the ECOWAS took a decision that countries should actually reduce their tariffs, and Ghana adhered to that and reduced the tariff that we were charging at the airports. Next slide, please. So I want to say a big thank you for listening. Thank you.
Thank you very much, Dr. Da Costa, for your really insightful remarks. And thanks to the other speakers as well. We will now begin the Q&A portion of this webinar. As a reminder, we will be using the Q&A function at the bottom of your screen for questions today. We will make every effort to answer as many as we can before today's briefing ends. And for those questions that we are unable to address in our time together today, our team will review and share responses via email after today's event. Our first question might go to Dr. James. What are the key challenges in Africa and the world to reporting on COVID-19 accurately and without politicizing it? What steps can journalists take to ensure that raw data they report won't be politicized?
Well, thanks for that question. What journalists have to do is to ensure that whatever it is they report has to be fact-checked. I was an associate editor of a Cape Town newspaper once called the Argus, and the fact-checking part of the operation, the media operation, was systematically cut back because of budgets. And this has happened in newspapers. This would be print newspapers as a whole. When it comes to social media, you know that's uncurated. So there's a responsibility on media organizations and journalists to make sure that the information they actually provide has been fact-checked for accuracy. And I would think that that will make a big difference in terms of ensuring that, that there is no politicization that's based on that. It's not guaranteed, but certainly they can make a contribution in that respect.
Thank you, Dr. James. I would love to throw this question also to Dr. Da Costa. Dr. Da Costa, what advice would you give journalists struggling to report on COVID-19 accurately and without politicizing? How has your team perhaps worked with journalists in Ghana to do just that?
Thank you so much. Often what we do is we organize, obviously, orientation sessions for journalists. And like this that I'm presenting, we've called Ghanaian journalists to also be on so that they are able to know and report accurately. This is why I highlight I highlighted some of the things that can be reported. Reporting facts, not myths. Reporting facts, not misinformation. So we have good websites like the Resolve Save the Lives website, PERC website, the Ghana Health Service website, WHO website, trusted websites for information so that they are able to get the right data to report. Thank you.
Thank you very much. And I might add a few other resources to that list. Africa CDC has a treasure trove of information on its website. And there are other websites like Africa Check, which is an effort to catalog and debunk common myths, including on COVID-19 and COVID vaccines. So to anyone who hasn't checked out those resources, they might be very helpful to you. Let me ask a question to Virginia. What is the single most important thing to keep in mind when reporting on PERC data?
Thank you very much. So I think there are a number of things, but I'll maybe give them, I'll give the first one. The first thing is that the data needs to be looked at in relation to the changing context of COVID-19, both at a regional level and at individual country level. And that's why you see that in the data that we present, there are actually variations by countries, and these variations are informed by the different country situations. So that, I think, is one of the things that anybody should be looking at, whoever is looking to use this data. The advantage is that the PERC data is actually trended. So you're able to see what was happening in 2020 and how that has changed over time. But again, just to go back to what my colleagues have just said, it's also important to see what else is available, for instance, within the authentic sources like WHO, like Africa CDC, and the like. But yeah, that's what I would say is the most important. Yeah.
Thank you, Ms. Nkwanzi. And can I follow up perhaps and ask you what you found the most surprising finding in this latest go around for PERC?
Okay. I wouldn't really say surprising, but maybe concerning. So sorry to change your question, but basically for me, the most concerning thing is the low risk perception, especially at individual level. Because the more we have the low risk perception, then that means the behavior is actually not going to change. The adherence to public health and social measures is not going to change. And I know this might be because there are various pressures, there are different changes that the virus has taken in countries, but even for countries where we still see spikes in the virus, there is still a very low risk perception. So that is the concerning thing. Also surprising because ideally you would be expecting people to fear, but it's not the case. Yeah.
Thank you. That is indeed concerning, and of course a concern that we have around the world as we try to address the challenges related to the pandemic. A question for Dr. Da Costa. How do you compare COVID-19 vaccine immunity with herd immunity? Can you explain the difference between those terms?
Okay. So thank you very much. So herd immunity is just population immunity. I mean, it is that we are all not safe until everyone is vaccinated. And it is the reason why we still have to continue to adhere to the safety protocols. So if you realize we have been vaccinated, but yet we are still saying that the hand washing, the social distancing, the sanitizing, and all the others are still very important to help us all achieve country level herd immunity. So that is what I'll say.
Thank you. And could I ask you to perhaps comment also? Oh, sorry, Dr. James, please go for it.
Dr. James can ask something.
No, I just wanted to add to Dr. Costa's fundamentally important observation that it will always be a combination as we navigate, the world navigates its way through this pandemic, which every pandemic brings a surprise. The surprise here with asymptomatic transmission is, and then the generation of all manner of variants, is that we need to manage this over a period of time, right? And we're looking at the next 2 years. And it will always be a combination of vaccination and adherence to social measures in order to make sure that people do the right thing in terms of protecting themselves. It will always be a combination. So vaccines are an amazing biotechnological intervention that has emerged very quickly, and it is at the heart of a silver bullet, but it's not everything at all. So it's always a combination, just to emphasize that.
Thank you, Dr. James. Since you've raised the vaccine, and obviously that is at top of all of our minds these days, could I get you or perhaps Dr. Da Costa to comment on vaccine effectiveness, especially, of course, the COVID vaccines that are being used across the continent?
Thank you.
Yeah, Dr.
Thank you very much. Thank you so much. Let me say that the vaccines are safe. For Ghana, for example, when we get the vaccine, for example, the one we received from the AstraZeneca and COVAX, our FDA here, obviously, they are responsible for safety. They tested it to make sure that it is safe. Up till now, we set examples. Our president was the first to take. Nothing has actually happened to him. We took it. Myself, we the leaders of COVID took it. Nothing has happened to us. All the myths are just not scientifically proven. And you can see that these are just people trying to distract us from achieving the population-based herd immunity we want. But bear in mind, people also want information. So we need to report facts, not myths. So we need to obviously use our risk communication tools to make sure that we are informing our population of the safety of the vaccine. Vaccine saves lives. And the process of the vaccination was not short-changed. It actually went through the phases in terms of the phase 1, phase 2, and the so we should all bear in mind, and as journalists, what we have to do is to also make sure that we get to know the available information and use it to inform the population, because the population, being local, regional, and global, rely on you. What you say is very, very important to us, to the whole population. To accept the vaccine, but the vaccines are really, really safe, and we shouldn't have any cause of alarm. Let's all get it for the herd immunity that we aspire to get. Thank you.
Thank you, Dr. Da Costa. And looking at the time, maybe we'll wrap up with one final question for all panelists. If you could briefly share your key message on the question that I think is top of all of our minds, which is how much longer will we be dealing with COVID-19? I know this is a difficult question to answer, but what is your answer to the journalists attending here today? Maybe I'll start with you, Dr. Da Costa.
My message is simple. The vaccination should always go with the safety protocols, because we are not off the hood yet. And government should also make sure to reduce the impact of the COVID-19 on citizens. Thank you.
Thank you very much, Dr. James.
So Africa's challenge is a supply challenge. So we need to upscale the supply of vaccines through COVAX and through bilateral means. This is a major challenge. And secondly, we have to make sure that when vaccines arrive on scale, that the last mile is reaching, getting it into people's arms, which means we all have to make an extra effort to do everything we can to communicate the safety of the vaccines and their use in order to reach a level of herd immunity that is desirable.
Thank you, Dr. James. And Ms. Nkwanzi, please, your final takeaways.
Okay, great. Yeah, first of all, I won't deviate so much from my colleagues that have discussed about the vaccination. It's important to ensure that vaccine acceptance is increased and it's high. Another thing is, as much as possible, increase the change in behavior. The prevention behavior is very, very important. As much as we have the vaccine, they cannot go without the PHSMs. Where we are at the moment as a continent, we need as much as possible to follow the PHSMs.
Thank you so much, Ms. Nkwanzi. And with that, I want to thank all of our speakers for sharing this important and timely information from the PERC report today. The report provides data to flesh out stories of the economic and social costs of COVID-19, as well as individual attitudes about healthcare workers and government satisfaction. We hope that these data-driven insights will aid your reporting on the pandemic. The PERC report's finding that many people's hesitancy to take the vaccine stems from the belief that I don't know yet enough about the vaccines to make a decision. That finding gives journalists a powerful role in disseminating information about COVID-19 vaccines. Data suggests that this hesitancy could be remedied with information from trusted sources, such as yourselves, as well as the voices of political, health, business, religious, and community leaders you are able to amplify through your work. Information and advocacy campaigns for vaccines need to begin now, and in many cases, they are already underway. 2/3 of respondents indicated to PERC that they would definitely or likely get a COVID vaccine, but this varied widely by country. There is a need for a strong focus on local engagement with populations to ensure these vaccines campaigns are successful. The battle will be fought and won at the community level. In the event that we were unable to answer your questions, please reach out to press@vitalstrategies.org and our communications team will be in touch. Partnership for Evidence-Based Response to COVID-19 is now available online at preventepidemics.org. The report and recording of this session will be sent to everyone following this event. And so with that, thank you everyone for joining today. Have a wonderful rest of your day.